So welcome all of you from all over Europe, maybe even further. We say a warm welcome to our Young Internists webinar. I'm Irmengard Meijer. I'm resident of internal medicine in Germany. And with me today.
Hi, I am Lucía Ardieros. I'm from Spain. I'm an internist in Madrid. I'm also an associate professor at the Universidad Complutense. And we are really happy to have with us today Alberto Marra. He was the past president of the Young Internists, and he's going to tell us a lot about pulmonary hypertension because he's an expert in this topic.
Hello, everybody. First of all, let me thank Caterina and all the friends of the Young Internists of Europe. For me, it's like coming back home somehow, because I spent more or less 7 years working closely with the Young Internists, and it was an incredible journey, and I knew lots of people. It let me grow up from a professional standpoint, but also, I would say, by a personal standpoint. These are my disclosures, and today we will talk about a topic which basically it's very complex, because it's a condition that involves lots of people. It can be caused by several underlying disease. There is still some confusion about the proper wording and phrasing. So in order to guide you through this topic in this journey, I will let you present and know about one of my patients, which is particularly, I would say, paradigmatic, because it's a clear example and tapestry of what means dealing every day with pulmonary hypertension. During my presentation, we will try together with Lucia, Irgem, and fantastic moderators to involve you with interactive poll, and we will also have discussion during my presentation. So I will call this lady Sampdoria, since I am a huge football fan, and Sampdoria is one of the team playing in Italy. That comes to was referred to me from a general cardiologist. She is a 57 years old lady admitted to the internal medicine department for dyspnea for mild exertion. It began very, very slowly 8 years ago, but has been worsening and worsening in the last 2 months. And this dyspnea was defined by the patients something like, I can't even walk 5 steps of stairs. Past medical history was almost general, nothing really about some heart or lung involvement with an ischemic stroke in left thalamic region without any kind of neurological sequelae. There was a malformation, left parietal arteriovenous, renal lithiasis, partial thyroidectomy, and total pyridectomy for a pleomorphic adenoma. So nothing really special from a cardiovascular and respiratory point of view. She was really weak and tendency toward hypotension with the systolic pressure 100 above 60, heart rate 95. Saturation was okay, 95, and at the chest auscultation, she has basically a reduced murmur set basis. She has one-tone reinforcement of the pulmonary focus with a telesystolic 2/6 Levine murmur at the centrum without any kind of ankle swelling. So blood workup, biochemistry workup was pretty normal, slight anemia, slight increase of CRP, low ferritin, and very, very, very high NT-proBNP. So let's start with the first question. How would you start? Repeat NT-proBNP, because probably you think this value is too high and there were some mistakes in the lab. Start with performing an EKG, echocardiography, I mean, of course, or lung functioning test. So I hope now we have the pop-up of the questions.
While they are answered, this is the kind of patient we see every day in the ER, like patient with dyspnea, shortness of breath, they can't do anything, they complain of, sometimes they're like, I'm just old and nothing happened to me, but sometimes they're really, really complaining of that. But have you seen a lot of patients like this?
Of course, this was a patient referred to an internal medicine ward, so we weren't in an ER. The patient has never been visited really much. So nobody took care of visiting, making a chest auscultation and so on. Probably in the ER, you don't have even the time. I mean, we don't have to blame colleagues in the ER, because maybe while I visit one patient, they have 40 patients to take care of. Probably this could be one reason why. Do we have results of our poll? Maybe. Okay, interesting. 11% voted for repeat NT-proBNP. The majority said EKG and echo, and only 3% said lung function intact. So the mind goes directly to the heart, I would say, from our audience. And basically is what we did. So EKG, right alier deviation, right branch block with ST axis a specific abnormality. You can see the T waves very, very negative. After the right branch block, we performed a 6-minute walking test. We weren't able to end it because the lady stopped it after 1.5 minutes, only 140 meters traveled due to dyspnea, and normal values are around 400. We did echo, and while we did echo, we were able to see, first of all, that the right chambers were larger than the left one, as you can appreciate in this 4-chamber room. We see a very important and severe tricuspid regurgitation, moderate to severe, with a peak tricuspid velocity around 4 meters. And what was surprising was this one. You can see how much the septum were shifted to the centrum of the left ventricle, giving to the left ventricle a sort of this shape with a very large right ventricle. So are we ready to make a diagnosis? Yes, echo is able to make a diagnosis of PH. 2, we can say that the patient has pulmonary hypertension, but no specific diagnosis is possible. We are just at the beginning of the journey, and I need a drink now, don't bother me any longer, which could be probably one of the of the correct answer.
Well, the last one is probably the answer the doctor would love to hear. But are you able to perform an echocardiography on every patient that you see in your practice?
I wish I could, or we wish we could. And probably something that we should bring to students, because it's the new modern stethoscope echo. The point is that most of the people, the doctor, even cardiologists, most focus on the left side, and on some report you don't even read nothing about the right side. It's like they hide or they neglect it. This is, I don't know how many of you read the reports of echo that telling some stories about the right heart. I think nobody.
Not enough, definitely. But do pulmonologists do or perform echoes at your hospital as well? Or do you send the patient to the cardiologist for the echo, and when they come back, you read the report?
Myself, I can do echo by myself. When I was in Germany, the pulmonologist could, since they are, I was working in a pulmonary hypertension center. More or less in Italy, a little bit, all the internists can do bit of echo, at least fast protocol. I don't know in other countries. Okay, let's see the results, what the people said. So 12% said yes, echo is able to make a diagnosis of pulmonary hypertension. We can say that the patient has pulmonary hypertension, but without specific diagnosis is possible. 37. half of the people said we are just at the beginning of the journey and I need the drink now, collected no answer. So everybody is serious and they don't want to drink nothing, which is...
I'm kind of disappointed at that.
Yes. So those were the parameters. So we had TR peak velocity of 5.43, very enlarged right atrium area, an estimated pulmonary pressure of 83. TAPSE was okay, so the contractile function, the systolic function was okay. On the left side, nothing to report. And the conclusion was that the patient has estimated high pulmonary pressure with associated right chamber dilation and reduced indexes of pulmonary arterial coupling, with a paradoxical movement of the septum and transversal D shape of the left ventricle. This is basically the question. So what is pulmonary hypertension? What is a disease or is a clinical condition? And maybe we can have also a question about this, because this is the point that sometimes we found out on the ECHO report. So
that is true. In our hospital, often the person who performs the echo says, well, I know this is pulmonary hypertension. What can we answer if this question comes up?
It depends. It depends because it depends on basically, if he only says this is pulmonary hypertension, it's okay. If the people who report claims to say this patient has pulmonary hypertension because of blah, 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 he can do for some cases, but a final diagnosis is basically not possible with ECHO. And this is what also our audience reported. So I'm curious to see what the audience say about the question. So 26% say this is a disease, and 74% said this is a clinical condition. So 1/4 of people thinks that saying that the person has a pulmonary hypertension is enough to say that this is a disease. Well, actually, this is basically not true. Because when we say that the patient has a pulmonary hypertension, we just saying that the person has one parameter which is higher than normal. It's like saying that the person has a fever. You have fever when your body temperature is above 37 Celsius degrees. The same is with pulmonary hypertension. We say that a patient has pulmonary hypertension only after that we measure the mean pulmonary arterial pressure above 20 millimeters of mercury. And of course, as fever has a lot of causes, it's typical in our internal medicine world that we have patients with fever of unknown origin, and we start to investigate about infections, cancers, connective tissue disease, and so on. The same is true for pulmonary hypertension. When we say that a patient has a pulmonary hypertension, we say that this condition can be caused by several other underlying disease, like left-sided heart failure, lung parenchymal disease, chronic thromboembolism, or pulmonary arterial hypertension. And pulmonary arterial hypertension is the most characterized form of pulmonary hypertension. What is pulmonary arterial hypertension? Is a rare condition which is caused by enhanced and uncontrolled vasculopathy of the lung microcirculation, which is characterized by intimal fibrosis and hypertrophy of the medial tunica with hyperplasia of the smooth muscle cells, which leads to occlusion of the small lung vessel, which in turn cause increase in pulmonary vascular pressure, then increase in pulmonary pressure, and increase afterload of the right ventricle. This is a very rare condition. It was described in Germany more than almost 1.5 centuries from now by this colleague, Professor Dr. Med Ernst von Romberg, who spoke after performing an autopsy on a typical lady that died young from this respiratory failure and right heart failure due to pulmonary arterial hypertension. He spoke about isolated sclerosis of the lung arterioles. which is basically what is pulmonary hypertension. So the point is like, when we see a patient, we just see the spike of the iceberg. We see that the patient has pH, so has increase in pulmonary pressure. We see after that this can cause right ventricular dysfunction. We are not able to see what happened directly in the lung microcirculation, in the precapillary bed, if there are endothelial dysfunction, abnormal cellular proliferation, and all the kind of molecular pathway that brings to this disease. So the point is that we are able only to have a hint that the patient had pulmonary hypertension just by performing a right heart cath. The right heart cath was performed for the first time by Dr. Conrad. At the time, he was a resident in cardiology, and as you can see in this picture, is the right heart cath that he performed on himself to describe the lung hemodynamic. And together with his mentors, they were awarded for Nobel Prize in Physiology and Medicine in 1956. Why it was so important? Because right heart cath was the first tool that we have during history to diagnose cardiovascular hemodynamics. You may think that at that time echo was not available, and in order to move into this difficult topic, several colleagues developed this kind of classification that is mainly divide all the causes of pulmonary hypertension into 5 categories. The first one is pulmonary arterial hypertension, which was also called in the past primary pulmonary hypertension, which is it can be idiopathic, or it can be from genetic causes, or it can be associated with several other conditions like connective tissue disease, HIV infection, portal hypertension, grown-up congenital heart disease, and schistosomiasis. On the other hand, you can have the group 2, which is pulmonary hypertension due to left-sided heart disease, either heart failure with the reduced ejection fraction, preserved ejection fraction, or valvular heart disease, due to lung disease, hypoxia, or both, so obstructive lung disease, restrictive lung disease, or due to pulmonary artery obstruction, which is the chronic thromboembolic PH or other kind of pulmonary artery obstruction, plus a number 5 category, which is composed by patients with multifactorial unclear mechanism. So some facts. Group 2 account for 75% of all PH, and it's followed by group 3, 12%, and group 4, 7%. And group 1 is a specific disease that is rooted on pulmonary vascular remodeling and plexiform lesion, and account just for 1% of the cases. The problem is that to date, a targeted therapy is available only to group 1 and group 4. So the only cause of pulmonary hypertension that we treat is just pulmonary arterial hypertension and chronic thromboembolic pulmonary hypertension. What's the problem? We are using a model, and we have probably to learn from physicists, and Feynman is one of the most important physicists of the last century that say something which is really important. So we try to understand the nature just producing models and to fit every patient in each category of our model. The problem is that nature doesn't care what we call it. She just keep on doing it. And it's not rare the case that you have overlap with a patient that is belongs to group 1, but has also some characteristic of group 2 or other kind of patients that has characteristic of group 1 and the same time also of group 3. So we should keep in mind that our classification is just a tool that we use to drive therapy, but patients can fall into overlap categories. Symptoms are particularly typical of several cardiorespiratory diseases. Patient has a huge dyspnea on exertion with fatigue, and they can also have dyspnea when bending forward, which is called bendopnea. They can have also sometimes chest pain, hoarseness because there is a compression of left pharyngeal recurrent nerve from the huge pulmonary arteries. they can have wheezing cough, they can have syncope. And those are symptoms that are due to the fact that the right ventricle is not able to cope with increased pulmonary pressure. It's not the same of the left ventricle, which usually cope with a pressure of 120, 140, even more. And the right ventricle, being not able to cope with such increased pressure, can easily undergo to a right heart failure. So how we can establish the diagnosis? How can we can estimate if a patient may have pulmonary hypertension or not? So we have a parameter, which I showed you before, which is peak tricuspid regurgitation velocity. And if we measure this parameter and we have a patient that has very high peak of tricuspid regurgitation above 3.5 meters, we have a high probability of pulmonary hypertension. In case of a patient has less than 2.8, we can rule out pulmonary hypertension. In case we have a patient in a grade zone between 2.9 and 3.4, we should have another signs at echo. Abnormal ratio between the basal diameter of the right ventricle and the left ventricle, the fluttering of the interventricular septum. We can have also the combination of the ratio of the TAPSE with the estimated pulmonary pressure less than 0.55, acceleration and reduced acceleration time of the right ventricle, enlarged diameter of the pulmonary artery, and also enlarged dimension of the right heart. So, saying all that, how would you proceed right now? Repeat echo. I don't trust him because he was an internist doing it and not a cardiologist. Lung function test plus CT scan, VQ scan, scintigraphy. And this is a crystal clear PAH, so right heart cath is necessary.
Just a quick reminder, you can all participate in the question that pops up now, but if you have further question, please use the question and answer, and we will get back to your question at the end of the webinar.
What do you think?
Well, this is a tricky question, isn't it?
Please.
Well, definitely, repeating a test is always an option if you don't think it's a factual one, and especially if you don't really trust the person who has performed it. So definitely checking the result is always to be considered.
But at the same time, you have to trust the person, because otherwise you have to repeat every second echo that you get back, and that is a waste of time or also resources. So I think in our hospital, number 2 would be easier to go on with. Because
you refer to the radiologist, to the pulmonologist.
Well,
and that's it. It could be an option.
If you know how to do the echocardiography, even a clinical ultrasound, you can quickly check some signs on the patient bedside or at the clinic. So you can confirm something really quickly.
I think that nowadays every doctor, especially internists, should be able to perform a small basic echo. It's something that probably should be performed. And even parameters of the right heart are not that difficult to assess. So probably we should focus on such things. But let's see what the audience answered. So majority say the lung function test and CT scan. And on this side, I mean, on this patient, we at this point, we completely neglect that probably a lung does exist. VQ scan in second, 8%. Repeat echo, 11%. So quite a lot of person say to repeat echo. Crystal clear pH, so right heart cath is necessary, 22%. Okay, so for 1/4, we had to go directly to right heart cath. And this is particularly true that we have to first of all, exclude all the causes of pulmonary hypertension. So lung assessment is part of the algorithm. So if we suspect the patient with pulmonary hypertension, we should go to do right heart cath. And this is what we did. Spirometry, 86% of F1 predicted, FVC 93%, so almost normal. DLCO only slightly impaired. CT scan, high resolution CT scan, absence of morphological changes to refer to ongoing inflammatory process, small spots of ground glass on mid-basal changes, which is something that almost all the patients sometimes displays. Blood gas analysis was reporting hypoxemia with low carbon dioxide. So was a patient in respiratory failure. We did lung scintigraphy that reported uneven distribution of radio compound in both lungs, with areas of increased hypocapture, the apical segment of the right upper lobe and basal segment of the left lobe. So a homogeneous picture of hypoperfusion. And then we went directly to right heart cath. From this video, the right heart cath is performed is an invasive procedure performed with a catheter which is called a Swan-Ganz catheter that has a syringe that is that guide the balloon that is inflated. So you go through the jugular vein. You can have also femoral access. You comes into the right atrium. Then you try to overcome the tricuspid valve, and you can appreciate once you are in the right ventricle with the rise of the pressure without any diastolic component. Then you try to go into the right ventricle outflow tract, and in this point you measure pulmonary pressures. You measure the systolic pulmonary arterial pressure, the diastolic one, and also the mean pulmonary pressure, that is the one that lets you make diagnosis. The balloon, what we use the balloon for? The balloon is important because once you measured pulmonary pressure, your work is not done. You have to measure this one, the wedge pressure, which is the pressure that we obtain after occluding with the balloon a small arterioles of the lung microcirculation, and is equal to the end diastolic pressure of the left ventricle. So if we have an increased wedge pressure, we can say that the pulmonary hypertension of these patients is due to the left heart, because it's a sign of increased left ventricle filling pressure. In case wedge pressure is not elevated, you can rule out any kind of left heart disease. Why we do that? Because what I told you before, left-sided heart failure is the most common cause of pulmonary hypertension. So it's particularly important to rule out this condition, since it's very common. And another parameter that we have to evaluate, it's the one called pulmonary vascular resistance. What is pulmonary vascular resistance? You know, always the example of the spike of the iceberg. We see, basically, when we see the patients, the increased tricuspid peak velocity, we see the cath, but what is in the lung of this patient? What is the stand of his pathological condition, the microvasculopathy of the lung microcirculation? We can estimate such impairment of the vascular bed just calculating this parameter, which is PVR, which is the ratio between the difference between MPAP minus wedge on cardiac output. Pulmonary vascular resistance is the most important parameter in stratifying prognosis of this patient, and it's even stronger than the pressures. So it's very important that once we make diagnosis of pulmonary hypertension, we calculate also pulmonary vascular resistance. And in the case of Sampdoria, the diagnosis was almost done. We had a mean pulmonary pressure more than 53 with the normal wedge pressure, very, very increased pulmonary vascular resistance, more than 4 times more than the normal values. with normal cardiac output. So the patient was affected by severe pulmonary vascular disease. So what's your diagnosis? Precapillary pH, post-capillary pH, combined pre-capillary, pre-post-capillary pH of pulmonary arterial hypertension. And also your opinion.
So it doesn't make it easy.
So let's say that all this stuff are basically important for the people that usually does CAT. So what is precapillary? What is post-capillary? Basically, precapillary is something that involves everything besides left heart disease. So precapillary, it's everything which is not involving the left heart. At this point, we have ruled out also the lung. We have ruled out the chronic thromboembolic because the scintigraphy was negative. So basically, we are almost done with the diagnosis. So let's see the results. So 45% said pulmonary arterial hypertension. 24 said combined, and 17 said precapillary, and 14 said post-capillary. So diagnosis was done for less than half of the patients. And this is basically the point. Another point is also that in this such patient, we have also to perform vasoreactive testing, because you can see even a patient that seems to have a pulmonary arterial hypertension but right heart cath, but at some level they have just a vasoconstriction, a huge vasoconstriction that is easily handleable with calcium channel blockers. And this is just 10% of patients presenting with idiopathic pulmonary arterial hypertension. And why this is important? This is important because such patients, if they have a positive vasoreactive test, they have a life expectancy which is basically equal to healthy subjects. So once we do the diagnosis, we cannot say directly this is a pulmonary arterial hypertension. We have first to perform a vasoreactive test. And if it is positive, you can give patient calcium channel blockers. And basically, they have a very, very good prognosis. Unfortunately, this was not the case. So the patient has a negative vasoreactive test, so we can conclude that she had pulmonary arterial hypertension. And this is an admirable example of what research can do to medicine, because pulmonary hypertension 20 years ago was basically a death sentence. There was no therapy. And there was the life expectancy was almost 1 year. After the introduction of up to 12 molecules belonging to 3 main classes of drugs, nowadays we were able to change the life of these patients. And nowadays life expectancy is something very, very good compared to the past. So it was pretty much a revolution. And in this case, which therapy would you start? Furosemide, triple upfront therapy with ERA, PD5, and prostacyclin, monotherapy with either PD5 or endothelin receptor antagonist, or upfront PD5 ERA therapy?
I think the first option is something every internist can do, but for the other options, I think some of us don't know exactly what all these shortcuts stand for. Maybe you can explain.
No, it's a tricky question. So just spend a word about furosemide. Furosemide, it's important, but only if the patient has sign of volume overload, which are wheezes at the chest auscultation, and she had basically ankle swelling. So more or less, she didn't show any ankle swelling, or maybe at echo, and we come back to echo on a large inferior vena cava. Furosemide, it's always a good option when we see such scenario. So for volume and fluid overload. We can give, of course, furosemide and diuretics, but with furosemide, we cannot lower the pulmonary pressure. So we're just adjusting symptoms. Let's see what they answered. Indeed, 13% furosemide, which is also a good option. Triple upfront therapy with ERA, PD5 and prostacyclin. Monotherapy, so one between PD5 of ERA, and upfront with ERA, PD5 therapy. So what are those such stuff? Maybe I was really bad, was a bad guy, because I told you about the drugs without explaining you. Basically, at the moment, we have 3 targeted therapy for patients with pulmonary arterial hypertension. So one is the endothelin pathway, and we have endothelin receptor antagonists, which are bosentan, ambrisentan, and macitentan. We have the nitric oxide pathway, and we can act on this pathway in 2 ways. The first one is reducing the degradation of guanylate cyclase with PD5 inhibitor, which are sildenafil and tadalafil, or acting directly to the guanylate cyclase with the riociguat. And then we have the prostacyclin. At the moment, the patient, we decide, according to the result of a landmark study, which is called Ambition, to combine endothelin receptor antagonist plus PD5. This is because, according to, and those are the dosage of the drugs. This is because when we decide the optimal strategy to patients, we have to refer to the risk stratification, which is the tool that we use to understand how severe is the disease of the patients we are in front of. We can divide patients into low risk, intermediate risk, or high risk, according to some criteria belonging to the clinical presentation, if it has signs of right heart failure, syncope, or progression of symptoms and clinical manifestation, the functional capacity, 6-minute walking distance, or in case we are able to perform cardiopulmonary exercise test, natriuretic peptides, BNP and NT-proBNP, right heart function, echocardiography, most of the cases, in case sometimes in some centers also MRI is performed, and the data from the right heart cath. Look into the data of the right heart cath. There is no mention of pulmonary pressure. So pulmonary pressure is important for diagnosis. When we have to stratify the severity of the disease, we have to refer to cardiac index, which is how much blood the heart is able to pump. Sorry if I am really rude, but this is the concept. And right atrial pressure. In our patient, basically, she had a clinical scenario that was almost no signs of right heart failure, but with a rapid advance of the symptoms without syncope. Functional class 3. 6-minute walking distance was really bad. NT-proBNP was really high. Echo was into the gray zone, and right heart cath data were more or less good. So whereas the typical cases of patients which has some severe signs of severe disease and some other signs of a mild disease. In this case, we were able to put the patients into the green, so intermediate risk zone, and we were able to give them macitentan and tadalafil. She improved after 3 months. 300 meters, so almost doubled the 6-minute walking distance, but still she wasn't able to finish the test. Echo was improved, the right ventricle became a little bit smaller, but still with higher pressure, but not in a very significant way. So she had a kind of improvement, but not a complete one. So now what would you do? Add another drug, prostacyclin, intravenous one, or oral prostacyclin, which is selexipag, add riociguat, which is an inhibitor of activator of guanylate cyclase, or refer to lung transplantation. What's your option?
Just a quick reminder for everyone that if you have any questions, you can ask them in the chat and we will answer them afterwards. As for your question, Alberto, do you have like a daycare hospital or something like that where you can administer treatment for these patients? Because I see the IV prostacyclin, and this is not for the normal clinic. Do you have some
Basically,
kind of
IV prostacyclin are thank you for the question, which is really good. For the oral treatment, it's okay in an outpatient setting. Of course, for prostacyclin, you can administer only with devices, with our pump, implantable pump, that are IV pump, which is very demanding for the patients and can cause site infection, but has the good side that the patient can administer. Very well-educated patients can change the dose of the medicaments alone, or they can have a subcutaneous pump with treprostinil, which is more easy and has less complication, but has the side effect that the patient has to come to the doctor each month to refill the pump. So it needs a very important and strong medical support. So let's see what the audience answered. So 61% would add Selexipag, 24% added Riociguat, prostacyclin intravenous 12%, only 3% to lung transplant. Well, lung transplant I would avoid because it's something that we reserve to very, very severe cases. Selexipag could be an option, absolutely acceptable, but we decided another one. In any case, when you follow up the patient, it's important to redo a risk assessment strategy. But in this case, we accept to have also, we split into 4 strata. This is because a study of the German group of the Compera study group. And in this case, we use only simple parameters. So once you have a prevalent patient, you do all the list. When you have the follow-up, you cannot repeat all the examination, but you have a more granular risk stratification. In this case, our patients was just between the yellow zone and the orange one. So we decided you can even add oral prostacyclin, like Selexipag, which was the majority of the audience decided to do. We decided in the first instance to switch from PD5 to Riociguat. Why? Because you know that nitric oxide is very, very important modulator that can stimulate the guanylate cyclate to produce cyclic GMP, which is a potent modulator of vasodilation and anti-proliferative action. The PD5 just inhibits its degradation. So when we antagonize PD5 with sildenafil and tadalafil, we just try to keep cellular GMP levels into the normal range. The problem is that once the disease advances, the endogenous nitric oxide levels becomes lower, and all the chains is broken, because then you have even lower and lower GMP levels. It's like when it's dark and you cannot illuminate a room with your natural light, and you have to turn on the light. And this is what Riociguat does. So it turns on directly guanylate cyclate in order to restore GMP level. And this is also important because this drug has also effects on the right heart. So these are data that I managed when I was in Germany. So the Riociguat is able to reduce the left heart size and improve also systolic function. So we are able with this drug to improve also the right heart function. And what would you add? So it's just stopped with the situation with this patient, or there is something to do? Diuretics, anticoagulation, refer to exercise training, or nothing. So once we treat pulmonary vascular disease, we are done. We are finished. We are over.
Did I understand correctly that we have 3 different medications now? And
Yes.
how long are we waiting to evaluate again?
3 months, other 3 months. But meanwhile, would you do something other?
Well, for cardiac patients or pulmonary patients, regardless of medication, I think exercise is always a good choice. I work in a thrombosis unit, and we always recommend patients to walk and do some kind of exercise, because that's the best thing you can do to recover. So I'm going for that.
I would join Lucia in that, because here we even have specialist or special groups for patients with pulmonary hypertension.
Basically, it's one of the things to do, because cardiac rehabilitation can even restore physical function. So if our goal is to restore exercise capacity of the patients, I mean, we cannot limit to treat the lung vasculopathy. Let's see what the people answered. Exercise training was the vast majority. Diuretics, 14%, anticoagulation 2%, only 6% said nothing. So most of the people said that there is exercise training to prescribe. Well, actually, most of all the question, besides the last one, the nothing is important. So when we manage a patient with pulmonary arterial hypertension, we have to keep in mind that we have several general measures to do in these patients. First of all, this is really hard to do, tough to do, since 90% of the patients are women and sometimes young. And we have to strongly recommend to avoid pregnancy, which is particularly hard to do for a physician. And why? Because once a patient with pulmonary arterial hypertension got pregnant, she has to stop medication, because they can have potential damage on the fetus. And women with pulmonary arterial hypertension having pregnancy has 50% of probability to die. It's like flipping a coin, basically. So it's very dangerous. Of course, vaccination, influenza and pneumococcal, psychological counseling, exercise training, absolutely important, supplemental oxygen only in case the patient has a lower oxygen level. Once they have surgery, it's better to recommend regional anesthesia. And also on top of that, of this general measure, we also have to give patient supportive therapy, diuretics in case of fluid overload, long-term oxygen therapy, as I said before. Anticoagulation is recommended only in idiopathic pulmonary arterial hypertension and in chronic thromboembolic pulmonary hypertension, no recommended in other forms. Iron deficiency correction in case ferritin level are under 100 milligram per deciliter per milliliter. We have to treat also comorbidities like arterial hypertension, and this is not uncommon that the patient that becomes hypotensive before the diagnosis, you give pulmonary vasodilators, then becomes hypertensive, because somehow you restore the cycle. And also arrhythmias like atrial fibrillation. Regarding the training, we were involved in a study in Europe called U-Training, and we were able to demonstrate that a standardized and monitored exercise program for patients with pulmonary arterial hypertension was able to improve quality of life and exercise capacity. After 6 months, indeed, the patient improved their 6-minute walking distance test, and she was able to perform at the end, no desaturation. NT-proBNP was very significantly reduced. Echo data were almost normal. The right heart becomes smaller. The pressures were lower. TAPSE improved up to 28. So we had a very remarkable improvement of clinical condition and echo. There is another point, the last one. Everything was okay, but nobody looked at the patient in the face and on the hands. And the last months, as you can see, she started to have some ulcers and puffy fingers on the hands. And we performed autoimmunity, and we were able to find that the patient has increased anticentometer and ANA levels. So we asked our rheumatologist to perform nail fold video capillaroscopy, and we discovered an early scleroderma pattern. So we also were able to perform ultra endoscopy of the esophagus, and we were able to do also esophageal manometry. So at the end of the day, we diagnose also scleroderma. So this case is important because it's somehow upside down. So we were able to diagnose first the complication and then after the underlying disease. And this is because probably nobody looked at the patients on the face and on the hands. And just a quick things to say also is that we have lots of trial with drugs with pulmonary arterial hypertension, with lots of drugs that we can use. The only point is that the cutoff of diagnosis were lowered during the last years. So it was 25 millimeter of mercury up to 2018. Now it's lowered up to 20. This is a problem because we don't have drugs for people between 20 and 24, so with the mild pulmonary arterial hypertension. We had an experience with ambrisentan, quite positive, and now we are performing a trial in 7 countries, with Germany, Italy, and Lithuania and UK, with to try to find also to demonstrate that also this patient with the mild form of the disease should be treated. There are future perspectives. Sotatercept, which is an antibody that is able to restore the molecular damage of this disease and has very, very, very good results that were published on the New England Journal of Medicine. So probably in the future, we will have also this immunotherapy for these patients. It's all ended? Unfortunately not. We have also to say something with to the other form of pulmonary hypertension. The first one, which is particularly common in internal medicine world, is chronic thromboembolic pulmonary arterial hypertension, which is defined by the presence of an occlusion of the lung bed from a thrombi. And there are 2 main phenotypes. The first one with the large thrombi in the proximal pulmonary arteries, and there is another one regarding the small vessel of the distal branches of the lung. This is a very rare condition, and what is important to stress is that in almost 25% of the patients, there is no report of a previous acute lung embolism before the diagnosis. And on the other hand, only 3% of the people who experienced a pulmonary embolism develop a chronic thromboembolic pulmonary hypertension. There are some risk factors, like the characteristic of the previous lung embolism, such as higher pulmonary arterial pressure at diagnosis, large perfusion defect, thrombophilic state, like elevated factor 8 of von Willebrand, lupus anticoagulant, and so on. Some comorbidities such hypothyroidism, malignancy, splenectomy, and why we do perform diagnosis with VQ scan? Because it's stronger than CT scan. And which is the pathophysiology? It's like we have an obstruction of some parts of the lung circulation. This led to higher flow and higher pressure in the not occluded segments of the lung, which brings to a remodeling that resembles the one of pulmonary arterial hypertension. What do we do in this patient? The first possibility, and this is the first line therapy, it's surgery. Why? Because patients that are operated have a better prognosis. In case we cannot operate the patients, we have a drug, which is again riociguat, and there is another possibility, ballon pulmonary angioplasty, which should be performed in center with strong expertise and can be performed together with riociguat. Just a few words for the 2 forms of pulmonary hypertension, which are very common but don't have any kind of treatment. Left heart disease. To date, we cannot use such drugs in patients that has pulmonary hypertension due to left heart disease. There is the problem is that into the chapter of left heart disease, we can have different kind of disease, from all kinds of heart failure up to valvular heart disease. The problem to date, the outstanding issue, is that we are not able to recognize among the higher number of patients with left heart failure those who has pulmonary vascular disease. Guidelines, the recent published guidelines of the last year say that probably we can try to use such drugs in patients that has higher pulmonary vascular resistance, but this has not been proved by any trial. Regarding lung disease, we have promising results by inhaled treprostinil in patient with interstitial lung disease, and we are waiting for trial that confirm these results. So I go to the take-home messages, and I left you with just another clinical case very briefly. Pulmonary arterial hypertension represents an admirable example of rare disease in which the use of molecules has ensured a marked improvement in clinical history of the disease. To date, we have 11 targeted molecules belonging to 3 classes: nitric oxide pathway, endothelin receptor antagonist, and prostacyclin. Risk stratification is very important to guide therapy, and we have to remember that in PAH, specific therapy is necessary to ensure that patients receive supportive measures like exercise training, oxygen and counseling, and general therapy with anticoagulation, vaccination, exercise training, and diuretics. The chronic thromboembolic form occurs in approximately 3% of patients who have had a pulmonary embolism, but 30% of patients with CTEPH have no history of acute previous pulmonary embolism. Therapy of choice of such form is surgery when feasible. In inoperable cases, or patients with persistent CTEPH after surgery may be treated with specific PAH drug, such as macitentan, and or balloon angioplasty. Form of PH secondary to left heart disease or respiratory disease currently have no specific therapy other than treatment of the underlying disease. Guidelines open a little windows to treat patients with left heart disease with PD5 with a severe vascular pulmonary involvement with the PVR more than 5 Woods unit. Promising data emergent from pilot trial with treprostinil in form secondary to ILD. It's all over? No, the things are not always simple. And I present, and before greetings from you, this last case, which I called Plato's Cavern. Obese man, former smoker, severe shortness of breath at minimal 4 with ankle swelling, hypotensive, low oxygen values, admitted in intermediate respiratory intensive care and managed with oxygen and thoracenemic infusion with a very, very bad 6-minute walking distance. Echo with the large right heart, with normal left heart function, increased pulmonary pressure, 95, with reduced systolic function of the right ventricle. CT scan, nothing particularly relevant, besides just some lymph nodes at left hilus with the small ground glass. Normal lung function, right arcade, almost clearly pulmonary arterial hypertension with mPAP more than 60, 66, low wedge pressure, very high pulmonary vascular resistance, negative vasoreactive test. So in this case, what was the diagnosis? Pulmonary arterial hypertension, pulmonary hypertension due to lung disease, unknown origin, or coffee because I let you sleep.
Now I'm definitely going to be the last one.
Where do you want the coffee?
But since we're still in the pulmonary arterial hypertension webinar, I think we're missing one of the groups. We already discussed the pulmonary arterial hypertension and unknown origin. That seems strange.
From the right arcade, it's a typical pulmonary arterial hypertension, basically. But of course, it's something different. Otherwise, I would not present this case. This is a good point.
But do you often have these cases that on first look, you don't know where it comes from? Or has every patient that comes to your clinic already gone through CT, cardiology, and the common
This is
scan?
the zebra, it's not the horse. Or if we consider pulmonary arterial hypertension already a zebra, this is a strange zebra. Let's see what the audience answered. Pulmonary arterial hypertension 30%, the coffee 12%, I would recommend, unknown origin 30%, and lung disease 27%. So the audience was splitted. We started therapy. At that time, we started only with one drug because we didn't have the evidence, and the patients was we were able to improve his condition. So 6 minutes was is the gray line, deteriorating, cardiac output was deteriorating, the heart becoming larger and larger, the green one, TAPSI, which is the systolic function of the right ventricle, was becoming impaired. We had drugs, we treated drugs up to the target dose, but no improvement. We added Ilopros, which is inhalative prostacyclin. The patient had the first right heart failure, and we switched from Ilopros with Repostinin. No improvement. Another right heart failure. He was a young patient. He's a young patient. He was listed through transplantation. He went through transplantation, and what we found was that he hadn't a pulmonary arterial hypertension. He had another very, very rare, rarest among the rare condition, which is called pulmonary vein-occlusive disease. In other words, pulmonary arterial hypertension involves, you can see the cartoon on the upper on the bottom of the slides, involves the blue zone, the arterial branch of the lung microvasculation. This disease involves the venous branch. So if you give vasodilator that acts on the arterial branch of the lung microvasculation, you can cause pulmonary edema. So it appears to you hemodynamically at right arcade as a pulmonary arterial hypertension, but it's not. And this is the point. So we are able to do a diagnosis with right arcade, but we have only hemodynamic data. We don't know at the moment what happens in the pulmonary vascular bed, because at the moment we don't have any kind of biomarker of pulmonary vascular disease. This is what we expect in the future, in order to discriminate not only patients with pulmonary arterial hypertension with those without, but also to see among the common conditions such as left heart failure, lung respiratory disease, those patients that has on top pulmonary vascular disease. So this is something that we have to do. And this is particularly important in heart failure, left side, because this is a very elegant study performed in the United States, where they were able to demonstrate that patients with heart failure, left side heart failure, has vasculopathy of the lung microcirculation, which is closer to pulmonary vascular vein-occlusive disease, more than PAH. And this is the reason why drugs of pulmonary arterial hypertension doesn't work in this disease. Why Plato's cavern? Because Plato's cavern is a admirable example that Plato used to describe cognitive and how we learn about life. He said that man lives in a cavern and they see only the shadow of the things projected on the wall. And these are the shadows that we see, the clinics, echo, but what is behind the shadows, the pulmonary arterial hypertension, systemic sclerosis, is the reality. And how we can see the reality just with critical thinking, the reasoning. And clinical reasoning is always important to let men escape from the cave. So we should have been able to use clinical reasoning and use all the knowledge that we have. And the problem is that every patient is a challenge. Maybe those who are more able to use clinical reasoning are the internists. And I left you with two things. The first thing is I'm very happy to be here because we were the first to launch webinar in the EFIM even before the pandemics. This was a webinar in 2019 while I was chair about burnout. And why we did that? Because we always follow Utopia. And Eduardo Galeano, which is an incredible writer from Uruguay, said tell this story. Once they asked him, Maestro, what is Utopia? And he answered, Utopia, it's like the horizon. I walk 2 steps and it visits 2 steps. I walk 10 steps and it goes 10 steps away. Then they asked him, what is Utopia for, Maestro? And he answered, it serves human beings to walk. So somehow we need Utopia. So I hope I didn't bore you very much, and I hope you enjoyed my talk.
Thank you very much. What an impressive talk that you gave us to see how varied the field of pulmonary hypertension can be, from a woman that seems normal at first sight, who turns out to have already the impairment of a complication of a disease, up until the last patient who needed a lung transplant after diagnosing a disease that I suspect most of us have never heard of. So thank you for your expertise, and we're happy to receive more questions. We have the first one in the chat. And well, we have a few minutes, so
Absolutely.
Let's start with the first.
I have a question before we start with that. When we talk about pulmonary embolism, we always say that we should perform a mammography. And in my unit, the first question everybody asks is, why a VQ scan? Why not a CT scan? Or if you want to see the thrombi, why not do a CT scan so you can actually see it? So can you tell us why we should perform the ventilation perfusion scan and not a CT scan?
It depends on the setting, of course. If you're in the emergency department and you have an acute patient with pulmonary hypertension acutely onset, probably you have to perform CT scan in acute setting. The problem is that when you have a patient with chronic dyspnea and you are not able to discriminate between the acute lung embolism and a chronic one, in some centers, they are able to discriminate with a very experienced and trained radiologist. Normally, it's very difficult. VQ scan, when we are trying to discriminate if a patient has a chronic thromboembolic pulmonary hypertension or not, it's the choice because it gives you a functional data about the perfusion and the ventilation, and the perfusion-ventilation mismatch. And this is why probably in case of discriminate between an acute and chronic patients, you should start with the VQ scan. Of course, in the emergency department, you need to solve the problem right away in that moment. And probably VQ scan gives you the idea if the patient has a large thrombi, and then you have to start anticoagulation soon, or even thrombolysis in case of a shock, a patient in shock. So the setting is different. When it's a chronic dyspnea, probably better VQ scan. Of course, after you did the NICO and you see right heart increased pulmonary pressure and so on.
Thank you. We have one question. So if I have a patient that I suspect of pulmonary hypertension, at what point do we, as, for example, as a family doctor or as a general internist, refer the patient to a center, or what would you suggest as first diagnostics to perform before referring the patient to, for example, your day clinic?
Well, very, very point really well taken. It's very difficult to answer. Basically, it happens that general cardiologists, because let's put our feet into the patient's shoes. They have dyspnea, they don't know why. So the first doctor that they see in 90% of the cases is a cardiologist. The cardiologist usually is able to do echo. So the patients to refer is when you have a patient with dyspnea and you see that there's a very large right ventricle, right heart, with the normal left heart. This patient is a patient that has to be referred to pulmonary hypertension center right away. And then after in the center, you will do the algorithm and discriminate between the underlying causes. Clinical data that can help is that if it's a patient that have a very abrupt and sudden in the last weeks or month onset of dyspnea, if it's a patient that has an underlying disorder that can be linked with pulmonary hypertension, such as connective tissue disease or HIV or grown-up congenital heart disease. However, in this case, they are already followed because patients with grown-up congenital heart disease are managed in some specific clinics. And then this should be the starting point. It happened to me that I was referred the patient from the ER. He has an echo which was really, really suggestive of pulmonary hypertension, with a huge right heart, very small and normally functioning left heart. And he was treated for 2 years as a COPD. And the things that really, really was into my mind, I was visiting it with my friend on the ward. We made chest auscultation, was normal. And nobody put a stethoscope on his chest. He died. We weren't able, he was so sick, so ill, that the day after, we weren't able to perform right heart cath. It was planned the day after. He arrived in the afternoon. So the right heart cath was planned in the morning, and he died during the night. He was very advanced, and nobody treated him or treated with wrong medication, because I do not claim that every doctor can use echo, but at least that can use stethoscope is something that probably is a soft skill that probably everybody should use. And if I think that the patient has COPD just because he smokes and has a normal chest auscultation, there is a mismatch. You know what I mean? So clinical reasoning before everything.
Okay, there's another question here. How do the roles of finerenone and SGLT2 inhibitors can be incorporated into treated pulmonary arterial hypertension?
I do believe that SGLT2 and finerenone, okay, probably preventing the progression of renal disease can have a role. They are not tested, but I know that they are trying to test. SGLT2 inhibitor, who can answer? Nobody expected that a drug that started as a diabetic drug then become drugs for heart failure and kidney failure. Can have a role also in pulmonary hypertension? Why not? With these drugs, you can expect everything because we don't know the mechanism. I think that SGLT2 inhibitor may have a role, especially in those patients that has right heart failure, because with current drugs, we treat only lung microcirculation. We do not treat right ventricle. So it's possible that SGLT2 can grant a patient something like heart protection, and the right heart becomes stronger.
Thank you. Our next question, probably this colleague is an internist, asking herself or himself at what point do I, as a general internist, start treating pulmonary hypertension? Or is this really the field of the specialist?
It's a good question. When I was in Germany, my boss was an internist and then a cardiologist. I knew several internists that are making pulmonary hypertension, arterial hypertension. So in my mind, an internist can handle everything. Of course, to handle such a disease, you have to spend a fellowship in a center with lots of patients that you can see lots of patients and you improve your knowledge. But as background knowledge, being an internist, it's, in my opinion, the best option because you know a bit of cardiology and pneumology doesn't. You know a bit of pneumology and cardiology do not know pneumology. You know a little bit of rheumatology because there is also systemic sclerosis. So you have to know immunity. You know emergency medicine. You know also ventilation. So an internist could be probably, and probably I have a huge conflict of interest because I am, probably the best doctor. So probably an internist plus a special fellowship on this topic could be a good option. Of course, you have to be able to manage radar cat, and this is not belongs to internist, but generally this disease is a disease that is handled by people that does pulmonary hypertension every day. No matter if they are cardiologists or pneumology or whatsoever. I do remember in my group in Germany, when I was in Germany, we had our boss, he was internist and cardiologist. We were two pneumologists, one rheumatologist was myself, internist with, was able to do echo. So it depends on if you spend the right fellow on this topic. You have nothing to invite to other specialists.
Okay, so it's really something to refer from the general practice further to the specialist level. We will come to our last question.
Where would you recommend using the spiral ergometry, the cardiopulmonary testing, in the management or the diagnosis of patients with pulmonary hypertension?
Nice question. And cardiopulmonary exercise test is very, very helpful. Why? Because it generally tells you where the dyspnea comes from. And it's important because generally you can see the patient with the functional impairment with lower peak oxygen consumption, because it belongs to all kind of cardiorespiratory condition. You can rule out a respiratory disease seeing if the respiratory reserve, so how goes the ventilation, and there are two specific parameters that are related to pulmonary vascular disease, which is the slope of the ventilation VCO2 curve, which tells you how much is the perfusion ventilation mismatch, and you have PET CO2, which is the how much CO2 you can expirate at peak exercise. Those two parameters are really helpful in discriminate patients that has a pulmonary vascular disease. If they have a pulmonary arterial hypertension, where the hallmark is the pulmonary vascular disease, or if they have a pulmonary vascular involvement in the context of a patient that has a left heart disease of the lung parenchymal disease. To my opinion, if we would like to treat patient that has left heart failure or pulmonary parenchymal disease, and we probably have suspicious that this patient should be treated with the pulmonary arterial hypertension drugs, probably cardiopulmonary exercise test and these parameters are the way to phenotype patients. But this is just my idea. I hope I will be able to demonstrate in the future. Or someone else which is listening.
Thank you very, very much. It is so interesting to hear so much about a topic that can occur every day. So we've learned that if a woman presents with dyspnea, we have to listen more carefully and not just send her away.
I hope so.
Absolutely. I would like to thank the Young Internists for making this happen and the technical support for supporting us every day until we got here. And we have some more webinars coming up, so tune up because there will be more topics, super interesting topics coming up.
And at the same time, we would like to remind all of you that there is the European Congress for Internal Medicine coming up in March this year, which will take place in Istanbul. And before we can all meet there and maybe discuss more on your specific topic, there is the submission date that has been postponed to the 10th of December. So everyone who still has a poster or an interesting case to submit, please do so. We will be very happy to receive everything that you want to share with us.
Again, thank you so much, Alberto, for being here today and sharing your expertise. It's been really, really great to hear. And
thank you so much.
Happy to.
I hope so. And also during the Congress, we will have a workshop, if you're interested, which is about how to write a manuscript. So we are looking forward to see all of you in Istanbul.
Then everyone, thank you for joining tonight and have a wonderful evening. See you soon.
Bye. Thank you for all.